Good day, everyone. Today, we'll be discussing the management of COVID-19 in primary care. While we have entered a phase of living with COVID-19, primary care remains critical in controlling transmission, managing cases, and preventing complications. Let's go through the latest guidelines and best practices. In this presentation, we will go through the overview of COVID-19 infection, the case definition for suspected, probable, and confirmed cases, the screening and testing of COVID-19, and we will also touch on infection control and prevention. Lastly, the management of COVID-19 in primary care. So, what is COVID-19? COVID-19 is caused by the SARS-CoV-2 virus, a respiratory virus transmitted mainly through droplets and aerosols. While transmission via contaminated surface is possible, it is less significant. Globally, there's a decreasing trend in COVID-19 morbidity and mortality, with high levels of population immunity to SARS-CoV-2. Despite a global decline in cases and death, maintaining vigilance in primary care is essential to prevent outbreaks and protect vulnerable populations. This updated recommendation is based on recent available evidence and applies across all disciplines. In primary care, identifying suspected cases of COVID-19 is crucial for timely management and infection control. A suspected case is defined as any individual presenting with an acute respiratory infection characterized by a fever of 38 degrees Celsius or more and a cough, with symptoms onset within the last 10 days. Alternatively, a person may also be considered a suspected case if they exhibit at least 3 of the following symptoms: fever, cough, fatigue, headache, muscle ache, sore throat, runny nose, shortness of breath, nausea, vomiting, diarrhea, or altered mental status. Additionally, any patient presenting with severe acute respiratory illness, in short, SARI, should be considered a suspected case of COVID-19. A probable case is defined as a clinically suspected case with epidemiological risk factors, such as close contact with a confirmed COVID-19 case or being linked to a known outbreak within 14 days of symptom onset. Additionally, an unexplained death with respiratory symptoms in the contact of a confirmed case is also considered probable. A confirmed case of COVID-19 is defined as an individual with positive nucleic acid amplification tests, such as RT-PCR or GeneXpert, or a professionally conducted RT-KAG test. Once a diagnosis is established, it is essential to classify the patient based on disease severity, as this guides clinical management. Stage 1 is for asymptomatic cases, Stage 2 for symptomatic cases without pneumonia, Stage 3, patients with pneumonia but without the need for supplemental oxygen, Stage 4 are cases requiring supplemental oxygen due to respiratory distress, and lastly, Stage 5 are critically ill patients with or without multi-organ failure. Proper triaging based on this classification is crucial as it helps determine the appropriate level of care, from outpatient monitoring to hospital admissions and intensive care. Let's quickly compare COVID-19 with other common infections. COVID-19 has a gradual onset, usually within 4 to 6 days, with fever, dry cough, fatigue, and sometimes loss of taste or smell. It spreads easily through droplets and aerosols and can lead to serious complications like ARDS and long COVID. Influenza, on the other hand, starts suddenly within 1 to 4 days with high fever, body aches, and cough. It's also highly contagious and can cause pneumonia or myocarditis. HMPV presents with flu-like symptoms but milder fever and spreads through close contact or contaminated surfaces. Dengue is different. is spread by mosquitoes, not person to person. It causes high fever, body aches, rash, and can lead to severe complications like shock and bleeding. Recognizing these differences helps in clinical decision making, ensuring appropriate management in primary care. In primary care, we should prioritize testing for patients with COVID-19 related symptoms such as influenza-like illness or severe acute respiratory infections. Routine testing for asymptomatic patients is not recommended, except in special cases such as pre-procedure screening. Now let's take a look at the infectivity period of COVID-19 and the factors that influence how infectious an individual may be. The median incubation period for COVID-19 is 5 to 6 days, but it can range from 1 to 14 days. This means that after exposure, symptoms typically appear within this time frame. Importantly, infectiousness starts to decline after day 5 illness, though this can vary between individuals. There are several key factors that influence how long and how much a person can spread the virus. First of all is the stage of illness. The highest viral load tends to occur just before or around symptoms onset. As the illness progresses, virus shedding and contagiousness typically decrease. Next is disease severity. Patients with more severe disease, especially those requiring hospitalization, may have prolonged virus shedding compared to those with mild or asymptomatic cases. Thirdly, is the immune function of an individual. Immunocompromised individuals such as those undergoing chemotherapy or those with underlying conditions may shed the virus for a longer duration, increasing the period of infectiousness. Lastly is about pre-existing immunity. Those who have been vaccinated or have had prior infection tend to have a lower viral load and a shorter infectious period compared to unvaccinated or previously unexposed individuals. Understanding these factors helps us determine how long someone might remain contagious and informs public health policies regarding isolation and infection control. Moving on to modes of COVID-19 spread. COVID-19 spreads primarily through respiratory droplets and aerosols when an infected person talks, coughs, or sneezes in close proximity with another person. Another mode of transmission is through direct contact with virus-containing droplets. If these particles land on the mucosa of eyes, nose, or mouth, they can enter the body and cause infection. Indirectly, if someone touches a contaminated surface and then touches their face, particularly the eye, nose, or mouth, they may also introduce the virus into their system. Lastly, COVID-19 is more likely to spread in indoor spaces with poor ventilation, where infectious aerosols can linger in the air for a longer time. This highlights the importance of good airflow and air filtration. After going through the mode of transmission of COVID-19, in this slide, we will discuss the key factors that influence the transmission. Understanding these factors can help us take preventive measures to reduce the risk of infection. First, environmental factors play a crucial role in transmission. These include poorly ventilated spaces where viral particles can accumulate and remain airborne for longer duration. Close proximity to infected patients, which increases the risk of droplet or aerosol transmission, and increased frequency or longer duration of exposure, as prolonged contact increases the likelihood of inhaling infectious particles. Another factor is the infectiousness of the source patient. The risk is highest when exposure occurs during the infectivity period, which is when virus shedding is at its peak. Not everyone exposed to the virus will develop an infection. Certain individuals are at higher risk, including immunocompromised individuals, unvaccinated individuals, and people not practicing protective behaviors such as wearing masks or maintaining good hand hygiene. Finally, the amount of virus an infected person sheds also impact transmission. Aerosol-generating procedures such as intubation or nebulization can significantly increase the spread of viral particles. Therefore, healthcare settings must implement proper precautions, including PPE and ventilation measures to protect frontline workers. That's why when managing infectious diseases like COVID-19, we follow 3 levels of precautions: standard precaution, droplet precaution, and airborne precaution. These measures help reduce transmission risk in different healthcare settings. Standard precautions are applied at all times when caring for patients, regardless of their infection status. They include hand hygiene, respiratory precautions like covering the nose and mouth when coughing or sneezing, practicing cough ethics using a tissue or elbow to prevent droplet spread, and proper disposal of waste and use of PPE when necessary. Droplet precautions are applied to patients with acute respiratory symptoms who require isolation. Healthcare workers should wear a surgical mask when within 1 to 2 meters of the patient. Patients should also wear a mask when being transported, and it is important to maintain proper hand hygiene and disinfect surfaces regularly. Lastly, airborne precautions are applied during aerosol-generating procedures, where fine infectious particles may remain in the air for extended periods. The key airborne precautions include using N95 or higher level respirators, performing procedures in negative pressure isolation rooms, and ensuring adequate ventilation in clinical areas. Not all COVID-19 cases require hospitalization. However, primary care should identify and refer cases with clinical instability, for example, hypotension, dehydration, poor oral intake, and hypoxia, or patients with uncontrolled comorbidities like diabetic ketoacidosis or acute decompensated heart failure. For pediatric cases, children with clinical category 3 or higher, or those category 2 with significant comorbidities should be observed and managed in hospital. The management of COVID-19 focuses on supportive care, symptom relief, and preventing complications. These are the key principles in providing general care for COVID-19 patients. Patients with COVID-19 illness should receive symptomatic treatment such as the use of antipyretic to reduce fever and discomfort, optimal nutritional support to maintain strength and immunity, and hydration and electrolyte balance to prevent dehydration and maintain organ functions. The principles of managing COVID-19 in pregnant and breastfeeding women are the same as for non-pregnant women. Essential medical intervention should not be withheld due to pregnancy, and breastfeeding can continue while taking necessary precautions to prevent transmission. For patients requiring bronchodilators like salbutamol, nebulizers should be avoided to prevent aerolizations of the virus. Use metered dose inhaler with a spacer instead for safer administration. For patients requiring supplemental oxygen, a trial of self-proning is recommended if tolerated. Continuous monitoring for oxygen desaturation is crucial to adjust treatment as needed. The routine use of antibiotic is not recommended unless there is strong clinical suspicion of bacterial co-infection. This is because unnecessary antibiotic use can contribute to antimicrobial resistance. The general care for COVID-19 focuses on symptoms management, proper oxygen support, and preventing complications. By following this evidence-based guideline, we can improve patients' outcomes and reduce unnecessary intervention. Now let's look at the risk factors for severe COVID-19 disease. The groups at higher risk for severe disease include older adults more than 60 years old, pregnant women, and those with comorbidities like obesity, chronic lung diseases, cardiovascular diseases, chronic kidney disease, chronic liver disease, diabetes, neurological conditions like stroke, and those living with disability and multiple conditions or frailty. Not to forget those who are in immunosuppressed states. Besides identifying risk factors for severe disease, early detection of warning signs is crucial to prevent severe complications in COVID-19 patients. Patients should be educated on symptoms that require urgent medical attention. These are the key clinical, laboratory, and radiological indicators that may signal disease progression. Firstly, clinical warning signs include persistent fever of more than 2 days, persistent symptoms such as lethargy, vomiting or diarrhea, worsening cough or breathlessness, reduced level of consciousness without alternative explanations, and signs of respiratory compromise like exertional dyspnea or desaturations, respiratory rate of more than 25 breaths per minute, SpO2 of less than 95%, or a 3 or more % drop in SpO2 on sit-to-stand test. Secondly, for laboratory warning signs, inflammatory markers showing a rising trend warrants extra attention. These include a rising CRP value or a single CRP value of 50 mg per liter or more, a rising ferritin level or a single value of more than 500, a raised LDH, and a neutrophil lymphocyte ratio of more than 3.13. Next, let's look at radiological warning signs. Chest imaging, either X-ray or CT scan showing severe pneumonia with extensive lung involvement, multilobular involvement, or rapidly worsening chest X-ray findings over a short period indicates deteriorating disease progression. Primary care should arrange early referral for these cases. Recognizing these early warning signs allowed for timely escalation of care, reducing the risk of severe complications and improving patients' outcome. In managing COVID-19 infection in primary care, the treatment approach depends on the severity of the disease. For Category 1 patients who are asymptomatic, no specific treatment is required. Patients with mild to moderate COVID-19 infection, classified as Category 2 to 3, can be managed in primary care, provided they do not exhibit any warning signs of deterioration. These patients should receive supportive therapy, including symptomatic management and monitoring. However, for those at higher risk of severe disease, antiviral treatment with Paxlovid should be considered. This flowchart outlines the decision-making process for prescribing Paxlovid in primary care. First, we should determine the eligibility for antiviral treatment. These include patients aged 70 years or older regardless of comorbidities, patients aged 60 years or older with significant comorbidities, or adults of any age who are immunosuppressed or have multiple significant comorbidities. Then, we assess symptoms onset timing. Antiviral treatment is only beneficial if initiated within 5 days of symptom onset. If beyond 5 days, supportive care alone is recommended. Before prescribing Paxlovid, we must check renal and liver function. If a patient has eGFR of less than 30 ml per minute or severe liver impairment of Child-Pugh class C, Paxlovid is contraindicated, and an alternative such as IV remdesivir may be considered with consultation from an infectious disease specialist. If no contraindication exists, a drug interaction check is necessary before prescribing. Lastly, the administration of Paxlovid should be adjusted according to eGFR level. Patients with eGFR of more than 60 should be prescribed 300 mg nirmatrelvir plus 100 mg ritonavir twice daily for 5 days. Those with lower eGFR of 30 to 59 ml per minute we need to halve the dose of nirmatrelvir to 150 mg together with 100 mg ritonavir twice daily for 5 days. By following this structured approach, we can ensure that high-risk patients receive timely and appropriate antiviral treatment while prioritizing safety and efficacy in primary care setting. When prescribing Paxlovid, it is crucial to educate the patients on key points to ensure safe and effective use. We need to inform the need for early treatment. Paxlovid is only effective if started within 5 days of symptom onset. Delayed treatment reduces its benefits. Then we need to look at kidney and liver function for contraindication and look for possible drug interaction. Paxlovid interacts with many medications, including statins, anticoagulants, and certain heart medications. Hence, we need to stress this to our patients to inform the doctors about all current medications, including over-the-counter drugs and supplements. When prescribing Paxlovid, it is essential to check for potential drug interaction. The interaction checker may provide 3 possible results. Green box indicates no interaction expected. This means Paxlovid can be safely co-administered with the medication. For example, perindopril, a common antihypertensive, has no expected interaction with Paxlovid. Next, orange box shows potential interaction. This indicates that caution is needed as the combination may require dose adjustment, close monitoring, or temporary discontinuation of one of the drugs. For example, amlodipine, a calcium channel blocker, has a potential interaction with Paxlovid. Alternative options or dose reduction should be considered. Lastly, red box means do not co-administer. This means the combination should be avoided as the interaction could be severe or dangerous. An alternative medication should be used instead. For example, simvastatin, a cholesterol-lowering medication, should not be co-administered with Paxlovid due to the risk of serious side effects. It should be withheld temporarily, or alternative statins like atorvastatin may be considered with proper monitoring. You may use this Liverpool COVID-19 interaction checker before prescribing Paxlovid, especially for patients on multiple medications, to ensure safety and prevent adverse effects. Thirdly, counseling should include dosing instruction and administration. When prescribing Paxlovid, ensure patients understand these key dosing instructions. Paxlovid is to be taken twice daily for 5 days. Each dose consists of 3 tablets taken together, 2 pink tablets, nirmatrelvir 150 mg each, and 1 white tablet, ritonavir 100 mg. Patients should take 1 dose in the morning and 1 at bedtime. Key counseling points should include informing patients to swallow tablets whole, do not crush, chew, or split, and to take Paxlovid with or without food. And reminder to complete the full 5 days course even if symptoms improve. Next, we also need to educate patients on the importance of adhering to their prescribed Paxlovid treatment course correctly for the full 5 days, even if they begin to feel better. Completion of the full 5 days treatment course is recommended even if the patients require hospitalization due to severe or critical COVID-19 after starting treatment with Paxlovid. Apart from that, they should also be counseled on missed dose management. So what to do if a dose is missed? If a dose is missed by less than 8 hours, take it as soon as possible and resume the normal dosing schedule. If more than 8 hours have passed, skip the missed dose and take the next dose at the scheduled time. Do not double the dose. In the event of an overdose, general supportive measures include monitoring of vital signs and observations of the clinical status of the patient. There is no specific antidote for overdose with Paxlovid. Lastly, it is important to inform patients on the possible common and serious side effects. When prescribing Paxlovid, patients should be aware of the most common side effects. For example, altered taste. Many patients describe a metallic or bitter taste with Paxlovid. However, this is temporary and resolved after stopping the medication. For diarrhea, it's usually mild and self-limiting. You may encourage fluid intake to prevent dehydration. Headache and muscle pains are usually mild. Patients can take paracetamol if needed. Last but not least, nausea. You may advise patients to take Paxlovid with food to reduce this effect. It is also important to talk about possible allergic reactions. Though it is rare, patients should be informed to stop Paxlovid immediately if they develop rash, swelling, or difficulty breathing and seek emergency care. COVID-19 is now managed similarly to other respiratory infections. There is no longer an official home surveillance order, but patients should be advised to stay home if symptomatic, minimize social interactions, and seek medical attention if symptoms worsen. The WHO Strategic Advisory Group on Immunization continues to recommend COVID-19 vaccination, especially for high-risk group, the elderly, immunocompromised, and pregnant mothers, as well as healthcare workers. For those who have not received any COVID-19 vaccination, WHO recommends 1 dose of the primary series for all adults and children with comorbidities. An additional dose is recommended for individuals who is immunocompromised due to their weakened immune response, which may not generate adequate protection from a single dose. For individuals who have already received their primary COVID-19 vaccination, booster doses are recommended for those at the higher risk for severe disease. This table is based on WHO Strategic Advisory Group on Immunization's recommendation on COVID-19 booster. Keep in mind that each cutoff varies between countries' policies, so it is essential to refer to the latest national guidelines for updated recommendations. Now, let's put our knowledge into practice with a real-world case. A 38-year-old fully vaccinated individual who is a close contact of a COVID-19 case presents with a 4-day history of fever, cough, headache, and dizziness. Vital signs are stable and SST is negative. What is the most likely diagnosis? What category does this patient fall under? What are the next steps in management? And does this patient qualify for antiviral therapy? Take a moment to reflect on what we have covered. You can find answers in the presentation. Discuss with your peers and specialists to determine the best approach. To conclude, COVID-19 remains a priority in primary care, especially in high-risk groups. Most cases are mild and can be managed at home, but early recognition of severe cases is crucial. Antiviral therapy benefits high-risk patients if started within 5 days. Vaccination and public health measures remain key in preventing severe outcome. Thank you for your time. Here are the references.